Hello friends, hope all of you can see me. Just give me 1 second. Right. Hi, good evening, Balu. So we'll start with the medicine questions. Um, as you all must have already been aware, the INICET exam this time was not really the way we anticipated it to be. Not much of clinical medicine questions. Looked like as if it was set by, with a lot of input from PGI and JIPMER. And as you know, particularly PGI immunology is one of the core factors, molecular biology and immunology. That's one of the essential areas that you have to prepare if you are going for the. I mean, that's how the PGI exam used to be. And a lot of basic science questions used to come from both AIMS as well as JIPMER. Plus, I think one very interesting thing that all of you might be already aware is that the 21st edition of Harrison has come. And once the 21st edition Harrison has come, I mean, it's just come now, but then I think they must have got their hands on it because I can see quite a lot of questions that they're asking are from the 21st edition Harrison. I think it's some kind of a joke we used to have earlier that, if Harrison comes out, almost entire volume of it is going to be dedicated to COVID. Unfortunately, I was reading the 21st edition and nothing like that has happened. I mean, they have got chapter 199, I think that's covering the COVID part of it. But then nothing new, nothing surprising, nothing extra. We thought so much will be covered on COVID by the new edition of Harrison, and nothing like that is happening. In fact, they are just referring to guidelines and they're saying, and certain websites, and they're saying go to those websites and be updated. So so all those jokes about most of Harrison being replaced by COVID now, that ultimately did not bear out. As far as the new edition of Harrison is concerned, they have added a lot of chapters on immunology. No wonder then that questions have come on immunology. They have gone into depth, and there are certain chapters that have been added, like in kidney, they've added an entire chapter on approach to nephrology, nephrological diseases. I mean, this was not there earlier. Now they have added a new chapter, and I'm expecting more questions on that. Maybe not in the NEET exam. NEET generally is not the exam where new guidelines or new stuff will come. It is going to be a typical routine paper that as we've been saying. But when it comes to the INICET, I think new books, new editions, what is new in that definitely gets captured, and they do ask in that in a lot of detail. So technical team behind the app is worrisome. I think they are working on it. I think our CEO, Dr. Nachiket, is aggressively working on the technical aspects. I'm sure that this is going to get resolved. As you said, that faculty are no doubt very, very good. And I'm proud to be part of a team that is really that good in, in conceptual approach in the subject. Are we supposed to go updates from new edition for NEET? Definitely not. As I just told you, I am going to emphasize once again. I think the NEET paper must have been prepared quite some time back, and I don't think that reading the 21st edition Harrison are going to have any impact in your preparation now, or how you're going to do in the paper. So I don't expect you to go through it. Actually, if we had got the paper, the book about a week before the INICET, they must have got hold of book a little earlier, the AIMS people. But I think if we had got the book a little earlier, maybe you could have got some idea what all new chapters have been added. I think based on that, we could have anticipated this kind of a paper. Anyway, I think this was to some extent a factual paper. This is the reason why I thought the medicine questions were not that difficult, but I think the pre-para subjects, the basic sciences were difficult, and I think that's the reason why. And always these subjects are, a pain. I mean, that's the main reason why we keep saying, okay, for INICET, your first year, second year subjects are going to be deciding what rank you get. So, without further thing, I just don't want to waste your time. Those of you who are going for the NEET exam, I want to tell you one thing. Please don't see this video. I mean, go back to your preparation. Once the this video is over, once the live video is over, then you can see it maybe at 1.5 or 2 speed if you can. I mean, you can see it later. In the sense, now you don't have to go through this, and because this is going to be slow, so you don't have to waste your time. You can see it later. Those who are not really going for the NEET exam as such this year, please participate in the discussion. As far as the questions are concerned, Just give me 1 second. I'll just adjust the. Right, I think this is better. Yeah. So as far as the questions are concerned, let's start with the first one. This is a question on a patient who's coming with elderly patient presenting with palpitations and chest discomfort. This is a patient who's got a stable blood pressure. As you know, any arrhythmia that we have, one of the first things that we see is what are the vitals. And if they're giving you a stable, hemodynamically stable patient, then first thing is you got to kick out the choice of cardioversion. Okay, cardioversion is out because cardioversion is going to be one of the most important options in the management of a patient. If the systolic blood pressure is less than 80, okay, if the patient is hemodynamically unstable, anytime you see a question where the BP is less than 80, then you know the answer is going to be shock. Okay, DC cardioversion is going to be first step. All patients, we're going to go for shock in unstable patients, and all the time the answer is cardioversion, with only two exceptions where you're going to go for defibrillation. And I think we've covered this extensively in the class. That is, in patients with pulseless VT and ventricular fibrillation, your answer is defibrillation. Rest everywhere, unstable patients, the answer is cardioversion. Now, among the remaining choices, first of all, I think this ECG is pretty straightforward. It's a patient who's got narrow QRS. As you can see in this kind of question, just give me 1 second. Let me zoom in. In this, anywhere, whenever you see the ECG, one of the first things you need to focus on is the QRS. If you find the QRS is narrow, then this is narrow QRS, generally telling you the problem is not in the ventricle, the problem is above ventricle. Now, what is the issue that I think many students told me was that there was ST depression. STT changes were definitely there in this ECG. So, when you see a patient having a tachycardia and you're seeing STT depression, then one of the things you need to understand, first of all, I think you all know that there's no P wave that is clearly visible here. In the absence of P wave and this very fast rate that is there, this is a clear picture of a and regular rate that is there in this case. It is definitely going towards a supraventricular tachycardia. Now, when you're looking at an SVT, many times you see SVT will come in the emergencies with ST depressions or ST elevations. I mean, sometimes a myocardial infarction also can trigger off an arrhythmia. The controversy that is there is in such a patient who's got this kind of an ECG, what do you do for the ischemic part of it? Now, one important idea is in most of these patients, the ischemia that occurs is simply because of a mismatch between oxygen supply and demand. The demand increased because of the arrhythmia, because the moment heart rate went up, as soon as the heart rate increased, the oxygen demand will increase. And if the patient is not able to keep up, either because the hemoglobin is not sufficient or the coronary arteries are partially blocked, whatever be the reason, the ischemia will manifest and you will see some ST depressions. And these ST depressions are simply a manifestation either because of ischemia triggered because of the arrhythmia load, or it is because simply a repolarization effect that occurs because many times, SVT has got two pathways, orthodromic and antidromic. The orthodromic pathway sometimes can come with this kind of ST depression. So one of the guidelines that is there, and I'll just show you the guideline, then you'll understand. This is the ESC guideline, same thing in AHA guideline also. And what the guideline is suggesting is any patient who has got an SVT, particularly arrhythmia like an SVT, in that patient, ST schematic alterations recording during during these kind of arrhythmias should not be used as evidence of coronary artery disease. Okay, this is class 3 recommendation, meaning this is, if you think it's CAD, it's going to be a wrong thing. It's a class 3, meaning it's harmful. So what you need to understand here is don't bother about the ST depression or the ST elevations. ST depressions and ST elevations could be simply a marker of the antidromic pattern of the arrhythmia, how it is depolarizing. The repolarization is picked up by ST, as you understand. So because of that, STT changes can occur. Meaning, simple idea that I'm going to tell you is just treat the arrhythmia. Don't worry about the ST depressions over here. It's just going to go away the moment the arrhythmia stops. The oxygen demand is going to decrease and the patient is going to be all right. So in this patient, as you all know, in a stable patient, if you find carotid massage mentioned in a hemodynamically stable patient for an SVT, the first answer is going to be carotid massage. If vagal maneuver is not mentioned, then as you know, the mnemonic is ABCD. It starts with A first, and that is injection adenosine, 6 milligrams IV stat you're going to give first. And then after that, if it doesn't work, then you repeat adenosine, and ultimately later you have options of other drugs, but the first drug that we always go for is adenosine. Okay, so you know the pattern. It is going to be vagal maneuvers first, followed by ABCD. Okay, what is ABCD? A is adenosine, B is beta blockers, C is calcium channel blockers, and D is you can go for DC cardioversion, digoxin. All the others have been coming later. So in this, since vagal maneuver is not mentioned, since the patient is hemodynamically stable, how do you know? The BP is 120/70. So in this patient who's stable, the answer is definitely going to be adenosine. Now there are some students, as you know, after the exam, every kind of thing, variations are there were some students who said, sir, it was not a regular RR interval, it was irregular. If they say, the moment they say it's irregular, that means now you're looking at atrial fibrillation as a possibility, in which case again the answer is don't go for PCI, don't go for thrombolytics. Anyway, you'll never answer thrombolytics when it's ST depression, right? So the answer in that patient, when you got irregularly regular rate, then the answer is going to be beta blocker, meaning just control the rate. The ischemia part will settle down, the ST changes will settle down, because if you get the rate down, the amount of oxygen requirement by the muscle will come down. So tachycardia itself sometimes can induce ischemia. So don't go chasing behind a coronary artery disease. It might just go away. The moment the heart rate comes back to normal, everything might settle down. So the answer in this question, based on this ECG, because I'm not given the exam, you people have, and most students told me it was simple straight case of SVT with ST depression. So the answer in this case should simply be adenosine. Pattern of questions for NEET, more of multiple type approach or straightforward, confusing in options. See, as far as NEET exam is concerned, based on our experience in the last few exams, what we saw, obviously you know that we don't have multiple patterns over multiple choice and all that over there. Generally, it's a single best response question. About 100 questions generally are easy. About 30 questions will be bouncers, which most people may not be able to handle comfortably. The competition will be in 70 questions. In that 70 questions, if you have read well, your concepts are good, you will be able to answer. If your concepts are not good, and if you are not read well, and if you just focus your preparation on memorization, you may not be able to handle those 70 questions. Meaning, based on what we saw last few years, that 70 questions are going to be the deciders, and that will really decide where you are, and each mistake that you make and each correct question that you have will shift your rank by a huge number. That's the problem that is there with NEET. Amiodarone instead of beta blockers given, doesn't matter. Even if amiodarone is there, in a patient with SVT, the answer is going to be adenosine followed by beta blocker. That is the way how we answer. Now, amiodarone you will only answer in a patient who's got a VT. For that, the QRS has to be broad. In this, definitely it was narrow QRS, and my repeated assessment with students was it was a narrow QRS tachycardia. It was not broad QRS. If the QRS is broad, then that's a VT. For a VT, you can consider amiodarone as the answer. Okay, if this is a narrow QRS, no question of amiodarone. Now, even if it's a broad QRS, there are two options you can consider. That is, if it's a VT, instead of an SVT like this, if it was a VT, broad QRS, then in that case, then you have two options. One is lignocaine and the other is amiodarone. The difference between the two is lignocaine works only in about 15 to 30% of patients. It doesn't work in everybody, but it works very, very fast. And our intention is to get the patient off the VT back to normal as fast as possible. So you will see many times in emergency, we give lignocaine, but it works only on a fraction of patients. But what works in almost everybody is going to be amiodarone. So somebody always loads amiodarone and keeps it ready. You give lignocaine first. If it doesn't work, then you switch over to amiodarone most of the time. That's one of the ways how we manage VT in an emergency in a stable patient. Now, unstable in a VT, obviously you all know the answer is going to be electrical, treatment. Okay, so in this question, I think the answer is straight. It is adenosine. So I showed you the ESC guidelines, and I was telling you that history becomes very, very important. Whenever you see ST depressions in a patient with SVT, you have to consider possibility of tachycardia itself inducing the ischemia, or the orthodromic pattern of AVRT will cause ST changes to occur. By the way how the depolarization occurs, the repolarization will get modified. That could be one of the reasons. Now, is there chest pain or not is the main question that you ask in this patient. If the patient says, I had chest pain for 20 minutes, 15 minutes, then I started feeling palpitation, that history itself is very classical, telling you patient suffered through ischemic heart disease. Because of the consequence of that, he developed arrhythmia. Okay, so which came first? Chest pain came first or the palpitation? That also is very, very important. And the most important thing we do is we terminate the arrhythmia. Okay, you gave adenosine, the arrhythmia went away. Let's say post arrhythmia, if you are seeing no STT changes, then that means the patient does not have ischemic heart disease. It was the arrhythmia that was causing the ST changes. Now, let's say patient was treated. Even if the heart rate did not come back to normal, the P waves started appearing. The SVT is gone now, because once you see P waves, clearly you can see P waves before the, I'm just zooming in. Can you easily make out that before every QRS you can see a P wave, you can see a P wave, you can see a P wave? Now this is not an SVT because P waves have appeared. Now, despite the presence of the P wave, still ST depression is there. Now this calls for possibility that the patient has a coronary artery disease, and that has to be investigated. You have to measure the troponins. You have to look at other features, and then consider further workup. Based on the pattern, if it's a patient who's getting chest pain at rest, then you treat it as an unstable angina or a non-ST related myocardial infarction. So I hope you understood the idea then, that We do not bother about ST. I think the biggest confusion some students had was, sir, there was ST depression. There was ST depression. There were so many people saying the same thing. Now, I told you again, ST depression, don't worry about it. Persistent ST depression after restoring the sinus rhythm, that's important. If there is chest pain, that started the whole thing. Followed by chest pain, the patient developed the palpitation, the tachycardia. That means it is ischemic heart disease that is triggering the problem. So you're worried about a coronary artery disease. If the tachycardia is causing the discomfort, chest discomfort, and tachycardia is the one inducing the ischemia, then you don't have to worry. Cure the arrhythmia, the pain also will go away. And obviously, if the biomarkers are slightly increased, we don't bother. They're significantly increased, and their serial biomarkers are showing increase. That clearly tells you we are now looking at a ischemic heart disease. So this is all the things that you should know as far as the arrhythmia is concerned. I think that question was pretty straightforward and easy. It was a classical supraventricular tachycardia. Only thing that put off some people were the STT changes. Do not answer PCI. Do not consider CAD. Do not consider giving treatment for ischemic heart disease in such patients. Just treat the arrhythmia. You're done with it. The pain will, the ischemic changes will disappear. Tongue fasciculations are seen in, and I think this question we've discussed at length in our TNDs, we have discussed this in our classes. We all know you have upper motor neuron and you have lower motor neuron. And when you look at the upper motor neuron and lower motor neuron is from the cortex to the spinal cord is corticospinal. From the cortex to the cranial nerve. Remember, cranial nerve can't fire on their own. The cranial nerve need input from above, from the cortex. So cranial nerve to, the cortex to the cranial nerve is corticobulbar. From the cortex to spinal cord is corticospinal. Both these are upper motor neuron tracts. When you're looking at the lower motor neuron, remember that this is the axon. What is there in the peripheral nerve is the axon. In the axon, the head of the axon, the nerve head of the axon is present inside the anterior horn cell and inside the cranial nerve nucleus. So if the cranial nerve nucleus is affected or the anterior horn cell is affected, naturally the nerve head is gone, then the axon will degenerate. This axon, the entire remaining nerve is an axon. Obviously, entire axon will degenerate. Whenever anterior horn cell is affected or the cranial nerve nucleus is affected, that's what we're calling LMN. Obviously, LMN can be anything from anterior horn cell to muscle. But the importance of fasciculation is because LMN can be so many things. If I just ask you, tell me some cause of LMN, peripheral neuropathy can cause LMN, muscle disease, nerve muscle junction disease, all these are lower motor neuron. But none of them will talk about fasciculation. The very mention of fasciculation locks your answer into either anterior horn cell disease or a cranial nerve nucleus disease. And because nucleus is gone or anterior horn cell is gone, this muscle might show fasciculation. And we discussed the concept in the classes that once you have a nerve that is dead, let's say this is an anterior horn cell or the cranial nerve nucleus, and you have the muscle, the muscle. If you have an upper motor neuron, this nerve continues to fire. Some neurotransmitter continues to cross, keeping the muscle stimulated to some extent. This also is the reason why you'll find that the muscle wasting does not occur in a UMN lesion. But if it's an LMN lesion, if this anterior horn cell is dead or a cranial nerve nucleus is dead, then there is no neurotransmitter crossing this. If there is no neurotransmitter crossing this, then there is upregulation of the postsynaptic receptor. This upregulated postsynaptic receptor can spontaneously fire sometimes, triggering twitching, and this twitching that are visible are called fasciculation. If you cannot see it and you can only record it, that's fibrillation. So I have discussed this in the class at length that there are so many LMN disorders, but the very word fasciculation anywhere in the question should hold you towards motor neuron disease. It's an MND. Now, once you have got an MND, after that your options are easy. If you find UMN, LMN, both features, that's amyotrophic lateral sclerosis. If the patient has got pure LMN problems, then that's a spinomuscular atrophy. If it's a pure UMN problem, that's a primary lateral sclerosis. So just going back to the notes that we have, and these are my class notes, and we mentioned fasciculations is a very important feature along with wasting in LMN. And this is the classification of the motor neuron diseases. And the repeat questions you all know, motor neuron disease cannot occur suddenly. It will take months to occur, number one. Number two, that the repeat things that they keep asking. Obviously, the pattern I told you already, that these patients are going to have either pure UMN, that is PLS, primary lateral sclerosis, or some UMN, some LMN finding, that is ALS, amyotrophic lateral sclerosis, or a pure LMN, which is called SMA. SMA is spinomuscular atrophy. Now, in this, what questions that they repeatedly ask in our exam are that No extraocular muscles are involved in any of the MNDs, no bladder involvement, no sensory system involvement. CSF is normal. This is a degenerative condition, not an infection. And most of these conditions are not going to have normal high mental functions. And these are repeat questions. That's why we highlight this in our classes. Okay, this is what you need to focus on. Okay, somebody is asking why not myasthenia? Myasthenia does not come with fasciculation. It comes with something called fluctuating weakness. The highlight of the question you will see is fluctuating weakness. You will not see fluctuating weakness in a myopathy. Muscle is damaged. You will not see fluctuating weakness. In a nerve or a element lesion, you will not see fluctuating weakness. The very mention of a patient who's got weakness for some time, he becomes all right. Morning he woke up, no ptosis, nothing, no diplopia, he's fine. After a few hours, he got diplopia, he's got ptosis. He exerted the muscle, he got the features. Then he took rest, again he's all right. That's a description for myasthenia. And as you all know, myasthenia typically comes more with ocular manifestations. Anyway, this is MND we're talking about. This amyotrophic lateral sclerosis we've covered at length, and I told you again repeatedly that the very mention of fasciculation, especially in the tongue, indicates to you that the 12th cranial nerve is involved. As you know, 12th cranial nerve can be involved in SMA and also in patients with amyotrophic lateral sclerosis. So as far as SMA is concerned, spinomuscular atrophy, it is going to come with muscle atrophy. Fasciculations is the hallmark thing. So you will see a child who is going to have flaccidity, diffuse flaccidity. When you hold the child, some of these patients, particularly Wernicke-Hoffmann's, this Wernicke, D is there here, Wernicke-Hoffmann syndrome. When you hold the child, because of the gross hypotonicity, it's like after pithing of the frog, in physiology you must have done, after pithing of the frog, the way the limbs are limp like this, that's how it will be because of the gross hypotonia. So that's what you see in Wernicke-Hoffmann. Much of these children don't survive for long. They pick up respiratory infections ultimately because respiratory muscles are involved, and they succumb because of that. But as you all know, treatment has come for this. The onasmonogene and the Zolgen SMA, that new treatment, as you all know, I think it goes into Crow's, the treatment, but it's curative. Okay, so we do have some treatment for this now. So anyway, these are the types. Ultimately, when you are looking for motor neuron disease in clinical practice, we always tell the student, examine for tongue fasciculation. Don't ask the patient to hold the tongue out. Don't ask them to hold the tongue in. The tongue should be calmly, carefully resting on the lower lip. Okay, just ask the patient to hold the tongue casually on the lower lip without putting any strain or effort, and you will be able to see the fasciculation. The moment you see tongue fasciculation, you got your answer. This is nothing but motor neuron disease. So I think MND is straightforward, and as we discussed, the very mention of fasciculation should alert you that the answer is spinomuscular atrophy. Now, GBS is going to come in a matter of few days. Okay, it might take sometimes up to 28 days, fine. But generally in most patients, GBS description in our questions will be over a period of few days. The patient started developing weakness in the lower limb, then upper limb. That's a history they'll give you for GBS. And never you'll see the word fasciculation. It does come with sensory findings where paresthesias, history-wise at least, patient will come with paresthesia before they start developing weakness first. That's a typical presentation of GBS. I told you again, myasthenia comes with fluctuating weakness. That's what you need to search in the MCQ. This weakness is not going to be constant. It will be fluctuating. Duchenne's is persistent progressive weakness starting in childhood, skipping, jumping itself affected. The hallmark finding you're searching when you're looking for Duchenne is calf hypertrophy. We used to call it pseudo hypertrophy of calf, but we can use the term calf hypertrophy based on Harrison's recommendation. So Duchenne's muscular dystrophy, that's the thing you're searching in the MCQ, that there should be calf hypertrophy. That's our anchor point. Okay, X-linked recessive condition occurs in males, calf hypertrophy, that's Duchenne. Rapid onset weakness starting within a few days in the lower limb, then involve upper limb. That's the picture you'll see in GBS. Some sensory findings usually in the sense it starts with paresthesias first. That's one of the features of GBS. Again, fluctuating weakness, predominantly involving the ocular muscles, ptosis, diplopia, then involving the bulbar muscles, that is muscles of swallowing, then starts involving the other muscles. That's the typical presentation you will see in patients with myasthenia. Which NEET PG will get cancelled or not, sir? Why will NEET PG get cancelled? Okay, we all have requirements of people to do post-graduation. So until they do PG seats in India, NEET PG will be conducted. I don't see how it will get cancelled. Sir, 12th cranial nerve involved in SMA? Yes, 12th cranial nerve can be involved in SMA. And we sometimes, they're saying spinobulbomuscular atrophy. Spinobulbomuscular atrophy and spinomuscular atrophy. They're saying is a continuum sometimes. And because it's a continuum in the sense that spinomuscular atrophy sometimes starts going up involving the brainstem, then it becomes spinobulbar muscular atrophy. So in many times, we still use the term SMA only. In a sense, even if it involves a bulbar, the cranial nerves, we still use the term SMA only. And Harrison is pointing this out. Okay, SMA, they're using for everything, including the brainstem as well as the spinal cord. So yes, it does involve 12th now. GB is also LNA. Yes, it is element type, but it will never cause fasciculation. That's an interesting feature, even though it's element. That's what I was telling you. There are many things that can cause element, but the very word fasciculation anywhere in the question should lock your thing towards the possibility of motor neuron disease. Now, can a normal person have fasciculation? Absolutely. You do a lot of gym, some fasciculation in the muscle. Sometimes your eye will be twitching. Sometimes you see some twitching in the palm. That is fasciculation. Now, can normal people have fasciculation? Absolutely. It does not have any significance, fasciculation without weakness. Okay, weakness with fasciculation should tell you the answer is MND. Can we expect INICET NEET PG questions for FMGE? Actually, the FMGE exam, unfortunately, I don't have much idea about it. I do, have a lot of interest in INICET and NEET. I think FMG, I may not be the right person to look at the answer for that. Will NEET 2022 be postponed? I don't think so. Okay, I don't think it will be postponed. Okay, so we finished with this question. Okay, so chronic hepatitis B serology, I think again we have discussed this at length in our classes. I'm sure most of you must have got this correct. So if you look at the hepatitis B serology, so we have two patterns we discussed in the class. One is acute hepatitis B and the other is chronic hepatitis B. Now, acute hepatitis B, if you look at the serological pattern, the first marker to come out from intact liver cells. Now, liver cells are not damaged still. The virus enters inside, starts replicating, and small proteins comes out first, and that is surface antigen. One of the earliest marker to come out, followed by increase in HBV DNA and the HBe antigen. As replication starts occurring, E antigen becomes positive. Then you find the first antibody to come out is the IgM anti-HBsAg. As you know, it's IgM, meaning it is going to go towards an acute presentation. Much of the acute, as you know, 90 to 95% of acute hepatitis B recover, and they are not going to have persistent infection all their life. They will recover, just like hepatitis A will recover, acute hepatitis B also will recover. So majority of these patients will develop an antibody. The biggest point to understand is the moment you have antibody against surface antigen, it is relief. It means the DNA is not there, the virus is cured. We don't have to worry about the virus sitting inside now. And this patient we declare as cured. In a patient with acute hepatitis B, this is a recovery point for us. Okay, antibody against surface antigen. Now, this is as far as acute is concerned. When it comes to chronic, unfortunately, the body is not able to clear the virus. Okay, in this instance, the surface antigen will always be there. Okay, surface antigen, this is S. Okay, I don't know whether it's looking like an E for you. Okay, this surface antigen is always there, right? This surface antigen, sorry. And this surface antigen is present for more than 6 months. Again, the first marker to come out, surface antigen. The initial antibody is IgM, but it switches over to IgG. And this is the IgG that is there. Now, IgM, the titers come down. What is persistent, this green line is IgG. So, two major antibodies you will see in the blood when it comes to, as you know, the core antigen never comes out in the blood. Only antibody is there in the blood, and they do not have any protective role. The presence of this antibody means infection is there, doesn't mean it's protection. And actually protection is by antibody against surface antigen. That's not there. In this case, surface antigen is there. So surface antigen plus IgG anti-HBsAg, these two are essential for you to label somebody chronic hepatitis B. If you get antibody against surface antigen, that cannot be chronic Hep B. That's a patient who's recovered, he's cured, he doesn't have the virus inside. As long as the virus is sitting inside, don't forget we are talking about a nuclear phase in the virus. This virus, it's very difficult to cure. As you know, it's not like hepatitis C, which has got cytoplasmic, completely the whole pathway is cytoplasmic. This enters the nucleus, very difficult to cure. Once a patient is chronic Hep B, then the patient more or less is going to be on lifelong treatment most of the time. Anyway, the patient is going to be surface antigen positive and IgG anti-HBsAg. Both these are required for you to make the diagnosis of chronic hepatitis B. So when you're looking at chronic hepatitis B, you know the essential thing, patient has to have surface antigen, without which you cannot say somebody is chronic hepatitis B. Okay, surface antigen has to be there. And I told you this antibody, IgG anti-HBsAg, will be there, and they do not have any protective role. Okay, this is going to be there. Now, obviously, when the virus is there inside, you can detect the HB DNA. So the correct answer is that 1 is correct, 3 is correct, and 4 is correct. 1, 3, and 4, wherever that is, that will be the answer. Okay, 1, 3, and 4. So again, I'm saying hepatitis B is very easy. I've seen some students getting confused with this. In acute, you can have an antibody response, antibody against surface antigen. Initially, surface antigen comes when the hepatitis B virus starts replicating. Intact liver cells, first marker to come out, surface antigen. You see the IgM anti-HBsAg, the body mounts an immune response. It clears the virus. The few cells, not all liver cells are involved in acute, remember, only about 10-20% of liver cells are involved. Most of the acute hepatitis B cases are not coming from vertical transfer, they are coming from horizontal. Either it's transsexual or blood transfusion, IV drug abuser, it came through that. It does not involve the entire liver, about 10-15% of liver cells are involved, and the immune attack hits them, it kills the cells, kills the virus, the patient is cured, antibody is there against surface antigen. This patient will have a window period because this is a phase of equivalence where surface antigen and antibody equalize each other, and you will not see. That's what we refer to as a window period. And the question they ask is, in the core window period, what's the antibody you'll see? What antibody you'll see is the IgM anti-HBsAg. Sometimes you also see anti-HBe antigen. So two antibodies you can see in the core window period: IgM anti-HBsAg and anti-HBeAg. Remember, all this is acute. This infection came through sexual, or it came through needle stick injury or transfusions. That's how it came, this horizontal transfer. When you're looking at the chronic, about 5% of horizontal transfer can become chronic, but much of the chronic happens through vertical transfer. When the neonate picks up, when the newborn has got the infection, the immune system does not recognize it as foreign. It does not attack. The infection is not restricted to few cells, it involves all the liver cells. Now, obviously, when it's all the liver cells, the inhibitors are there that will hold the immune response now. The viruses cannot be cured unless you're using some treatment. So you got surface antigen that will always be there. And inside you find the antibody. That antibody is the IgG, anti-HBsAg. Obviously, inside the liver cells, you will find the HBV that is present. And as long as the HBV is there, the hepatitis B is there inside the liver, the surface antigen will keep coming out. You all know chronic hepatitis B. When do we declare a patient to be cured? When you get antibody against surface antigen. That's very, very difficult to achieve. Harrison gives a table and it says about 3 to 5% of people can be getting antibody against surface antigen. Means you can declare a cure at the end of 5 to 8 years in some patients, 5 to 10 years. So it's very difficult to cure, as you all know, hepatitis B. So either way, I think we've covered hepatitis B in a lot of detail and the concept behind it. And this is a pretty straightforward question. So chronic Hep B, remember always, any patient chronic hepatitis B, surface antigen has to be there. Without it, you can't have chronic hepatitis B. IgG is the marker to get, and then DNA will be there if the virus is there inside. Okay, drug of choice for chronic hepatitis B and chronic hepatitis C. In patients with chronic hepatitis B, for a long time we used to use entecavir, and then we used to have the other options. But now we have tenofovir, and tenofovir, because we have a better, modified version, a kind of a prodrug of tenofovir, that TDV, that is the one, tenofovir alafenamide, sorry, that's the one now that's considered to be the drug of choice. So in most of these patients, nucleoside analogs are hepatitis B wise are the drugs of choice. And always remember, Harrison says hepatitis B is a monotherapy. Never use combination. Combination only gets side effects. There's no cure. Hepatitis C B is combination. Now, hepatitis C, there are various combinations that are there. The most preferred ones are sofosbuvir with velpatasvir combination. Now again, hepatitis C, Hep C, you never use single therapy. C means combination. We use combination therapy. So sofosbuvir, velpatasvir is the best combination. But apart from that, now depending on whether the patient was exposed to drugs earlier or not, has not taken drugs, does he have resistance, no resistance, whether cirrhosis there or not there, whether renal disease is there or not there. There are a lot of guidelines about what to choose if there is renal disease, what to choose if the patient has cirrhosis. And I think you need to refer to my lecture. In that I have covered in a lot of detail about the guidelines about each problem that is there based on what drug you can choose. But in general, if you just want to remember the best kick-ass combination for hepatitis C, the answer is sofosbuvir plus velpatasvir. That is supposed to be the best combination that is available for Hep C. Hep B generally is monotherapy. We have two options: interferon alpha, pegylated interferon alpha, or nucleoside analogs. In nucleoside analogs, I think tenofovir alafenamide is the best drug. Is surface antigen vaccine helpful before developing symptoms? Actually, once the exposure occurs, then giving vaccine may not have much benefit. However, you can use hepatitis B immunoglobulin, and along with vaccine has been tried, but hepatitis B immunoglobulin is more important. Once the antigen is entered inside, immunoglobulin is the thing, because vaccine takes time to act. So once exposure occurred, vaccine generally is not going to be of much impact. But before exposure, definitely vaccine is going to be very important. In that also, you all know, just because you're vaccinated doesn't mean you have protection. There is something called responders, non-responders. For that, we check the antibody against surface antigen. Okay, those of you who have taken the vaccine, you all know the main thing you will have in your blood. Okay, I'm sure most of you almost everybody amongst you must have taken the vaccine, and the only thing you'll find in your blood is going to be antibody and surface antigen. The titer of this is very important. If it's more than 10, then you have protection. If the titer is less than 10, even though you may have taken a vaccine, you are not having protection, means you need to repeat the vaccination by a different company. If you've taken Engrix, you have to go for the other company. So you have to change the company and repeat the vaccination once again. So again, those vaccinated individuals will only have antibody against surface antigen. The titer is important, and if the titer is more than 10, you're protected. Titer is less than 10, you might, if you get a needle stick injury, let's say tomorrow you're working in the ICU or in the emergency somewhere, you got a needle stick injury, you check the antibody, it was 6, let's say, that's less than 10, means you need to repeat the vaccination. In Brown-Séquard syndrome, which is wrong, English videos will be completely uploaded. Yeah, English videos will be uploaded by this month end, and trying my best to incorporate the 21st edition Harrison guidelines. And in the English part of it, I'm going to give it separately. In the sense, in the English part, I'm going to add the updates that are there in Harrison in the English version. In the English version, there only I'm trying to incorporate. Is Brown-Séquard syndrome, which is wrong. So Brown-Séquard syndrome, another easy question. As I told you, I think the medicine questions this time were not difficult. I think the pre-para subjects, that was what was, affecting the students. But medicine part was pretty straight. If you attended our classes, you got your notes, you would have got most of these questions correct. So in Brown-Séquard syndrome, you know what happens? There is a hemisection that is there in the spinal cord, and once half of the spinal cord is cut, the tracks that do not cross in the spinal cord, when you cut them, whatever is affected, same side symptoms will occur, features will occur. The tracks that cross, once you cut, opposite side manifestation will occur. So keeping that concept, ipsilateral, if you see, the patient is going to have posterior columns gone. So posterior columns means you will see proprioception affected. Okay, you know what is proprioception? Joint position and vibration, fine touch. So basically joint position, vibration together we'll call proprioception generally. So proprioception is posterior columns. Posterior columns do not cross in spinal cord. Whichever side you cut, same side joint position, vibration will go. And also you'll see that weakness is going to be on the same side, because corticospinal tracts also do not cross in spinal cord. If corticospinal tracts are cut, same side corticospinal tracts go down and supply antichon cells on the same side and supply the same side muscle. That's why weakness is also going to be ipsilateral. But you all know that spinothalamic tracts forms only after crossing. They pick up information from the opposite side. So because of this, whichever side spinal cord is cut, the opposite side you will see pain and temperature loss will occur. Okay, pain and temperature loss is going to be on the contralateral side. Now, these Brown-Séquard syndromes are quite rare. At one time, when we used to have wars being fought by the very primitive weapons, those World War I and all that, where you used to stand in front of each other and fire with that rifle. Most of these rifles have a bayonet, because they could fire 2 times from a rifle, then they had to reload. During the time when they reload, somebody from the enemy would run forward, with charge, and this fellow, seeing that fellow coming in the front with his bayonet sticking out, he turns and runs, and when he's turning and running, they pierce through behind on the back and half of the spinal cord. So these Brown-Séquard syndromes were very commonly seen in World War I. Not so much nowadays. Now it's more of trauma that can cause this, or war injuries. So ipsilateral, you see proprioception and weakness. Contralateral, you will see pain and temperature affected. So full section is definitely not correct. Contralateral pain and temperature, ipsilateral sensory, ipsilateral vibration, these 3 statements are correct. Obviously, this is not a full section but a hemisection. Okay, the word Brown-Séquard means it's a hemisection. Just give me 1 sec. I think my system is almost going to get off. Right. Okay, nobody's a teacher over here. Just like you, I'm also a student, and I think I'll be a student all my life, because medicine is too vast. Nobody can claim that they know everything. Okay, sir, will current final year studying students have next, or will they have NEET? Looks like it will be NEET only, and next might take some time to get get into the thing, but I'm not really sure about it. I think there are other people who are more informed who might be able to answer that question, but I think still you'll have NEET only, is what my feeling is. Anyway, Is it Brown-Séquard syndrome? So I think this is a pretty straightforward question. So this is from my notes again: ipsilateral side loss of proprioception weakness, contralateral side pain and temperature. How the patient will come in clinics? The patient actually will not talk about the sensory loss. They don't think about it or they don't notice it sometimes. What they notice is the weakness. The only thing patient will tell you is got weakness in one limb. So when you examine the patient, you will see weakness in one limb, but in that same limb, you'll see joint position vibration is affected. Opposite limb, patient is not talking about also. Opposite limb, you will see pain and temperature affected. That kind of a picture, if you're seeing, then that's when you say the patient has got Brown-Séquard syndrome. Okay, Sakshi is saying medicine was easy. I think I agree with you. Medicine is the easiest subject of all because it's very logical. Where all our pains and problems are these biochemistry, molecular biology, immunology. पसीने छूट जाते हैं उनको देख के. Which of the following is a checkpoint inhibitor? I think Harrison 21st edition is updated about the checkpoint inhibitors in a lot of detail. And this is the Harrison 21st edition table. And you can see all these drugs that are there. Okay, I'll just zoom in. I don't think you can see anything. So for each of these, okay, for melanoma, we have nivolumab and then ipilimumab, pembrolizumab. So basically what we're trying to do is allow the own immune system of the body to attack the cancer cells. And we don't want the T cells to get exhausted, the immune cells to get exhausted. So we are removing the checkpoints and we are allowing the attack from our own immune system. So these drugs are helping us, and that's why diseases, cancers for which we had almost said there's no cure, to some extent now we are able to get a control on them. And many of these checkpoint inhibitors unfortunately have a lot of side effects, but these are the only options that are there for these kind of aggressive cancers. So you can see the most popular among this keeps getting repeated is the pembrolizumab, and then you have nivolumab, and the very popular ones, at least the pembrolizumab, nivolumab, the ipilimumab, the atezolizumab. I think some of these you should be familiar with. Maybe you can't remember the whole list. Some of these new names very difficult to. You can't even they are kind of tongue twisters. You can't even get your tongue around them. But then I think the most important ones, at least for. I think this one, pembrolizumab, comes many places. It's used for lung cancer. It's got a role in melanoma. It's got a role in head and neck squamous cell carcinomas. So I think some of the very popular ones, at least, were definitely you should remember. So in this question, the question I think was accept. So the answer is cetuximab. Nivolumab is definitely, pembrolizumab is there, evolumab is there, cetuximab is out. Cetuximab actually is a epithelial growth factor inhibitor, and it is used for metastatic colorectal cancer. Okay, it's not a checkpoint inhibitor. It is used for metastatic CA colon. That's where we use cetuximab, but the other three are definitely our checkpoint inhibitors. Okay, the question I think was accept. Age-defining illness include all the following except, again, some of these I think are repeats. This is a pretty old repeat that's been coming frequently. It's a factual question, but in general, melanoma is a very aggressive cancer. Although skin cancers can occur in immune problems, in the sense if you have immunodeficiency, skin cancers can occur, but it's not melanoma. Okay, melanoma is a totally different game, and it is very aggressive generally. As you know, melanoma is going to have very high mortality. Anyway, Kaposi sarcoma is human herpes virus, cervical cancer, human papilloma virus, non-Hodgkin's lymphoma, so all the Epstein-Barr virus. So all these are connected with some or the other infection that might be triggering the cancer, and that's a general idea that these are infections that are triggering the cancers, and that's the reason why you are able to see that they are seen in immune deficiency problems. So anyway, this is again 21st edition Harrison table. The various things that have been described. Nowhere melanoma is mentioned in this table. So you do see candidiasis, cervical cancer, CME infections, histoplasmosis, Kaposi sarcoma, Burkitt's lymphoma, non-Hodgkin's lymphomas, many of them. So all these are the age-defining illness. Nowhere, obviously, in this list is melanoma. So it's kind of a repeat question. I think if you've seen the previous papers, you would have found this question in the past also. Clotting factor that decreases in pregnancy, and I think this is also a repeat. The answer is factor 11. Rest all the factors, pregnancy is a procoagulant state. So many of the clotting factors increase, particularly 7 and 9 are known to increase in pregnancy. Factor 1, factor 2, 7, 9, all these increase clotting factors. Particularly 11 is the one that you should be aware of that decreases in pregnancy. If you see a 45-year-old female presenting with easy fatigability, on examination she was found to be pale, hemoglobin was 6. I don't know why purposely they're trying to make medicine questions extremely easy and trying to make all the other subjects difficult. Why they're doing that, I have no idea. So which of the following is common in the peripheral smear? So any female coming with severe anemia, as you know that anemia of chronic disease never comes with a hemoglobin below 7. Then we have the thalassemias, but then thalassemias, such severe anemia again is not that common. And if you're getting such severe anemias, thal major can come with severe anemias, but those patients generally will be transfusion dependent. So this pretty much description looks like it's an iron deficiency anemia, which anyway in our country is the most common cause. And as you know, iron deficiency anemia is going to be a microcytic hypochromic picture. So unfortunately, these kind of questions do not have a differentiating power. I'm sure the toppers, all the people would have got this kind of question correct. Now, can you get other features? Poikilocytosis occurs in almost all anemias. It occurs in B12 deficiency particularly. It does occur in iron deficiency also. Target cells are seen in many places, particularly thalassemia is one thing that we think about. But can it occur in iron deficiency? Yes, target cells can occur there also. So either way, of all these, the most important is microcytic hypochromic picture, which is very classical for iron deficiency anemia. All are true about anemia of chronic disease except now in hematology we've discussed the concept of how iron is absorbed, how it is distributed, what role hepcidin has got in a lot of detail. So I think pure logic, we went into a lot of concepts about how hepcidin regulates iron absorption, its distribution across the body, and very logically I think we discussed about all these things. I mean I give you the a detailed concept about it. Now this is some of my from my notes again. Whatever iron is absorbed, it's absorbed in the ferrous form and from the divalent metal transporter. Non-veg, obviously heme directly can be absorbed. Whatever iron is there has to pass through the ferroportin channels, and the ferroportin channels, the ferrous that forms is attached to transferrin again in the ferric form, because ferrous participates in the Fenton reaction, is unstable, it's like a free radical, so the body keeps it in ferric form when it's transporting it. Any extra iron is there wherever, in whichever cell, whether it's the macrophage in the spleen or the liver or the bone marrow, any extra iron immediately is converted off to ferritin. Ferrous is ferrous. Ferritin, as you know, the covering of ferritin is ferric, and the deeper core inside is ferrous. Like in ferritin, what's the covering? It's ferric. Inside is ferrous, but outside is always ferric. Now, why is the body keeping everything ferric? Why not ferrous? Just as I told you, that Fenton reaction, it forms free radicals. It can be dangerous. That's the reason why wherever possible, it will be in the ferric form, transportation in ferric form, ferritin is in ferric form. So this is how it is happening. Now, one of the master regulators that is there from the liver, okay, you have the liver that is regulating. One of the things it produces is hepcidin. Okay, hepcidin. Now, hepcidin has got feedback controls. But one of the things that hepcidin does, its major action is it closes the ferroportin channels. Okay, what hepcidin does, it closes the ferroportin channels. Now, if this hepcidin is increased, then it closes the ferroportin. Once it closes the ferroportin, the loading of iron out to transferrin will not occur. And this iron attached to transferrin is nothing but the serum iron. Okay, it's nothing but the serum iron. Now, you all know daily so many RBCs are destroyed. The graveyard is the spleen. In the spleen, the macrophages will pick up the hemoglobin and recycle it. Okay, the iron is not wasted, it is recycled. Now, the macrophage also has got iron stored in the form of ferritin. So, the ferrous part will get converted to ferritin, which is ferric. And even the macrophages have got the ferroportin channels, and they also can load the iron onto the transferrin. That means transferrin can pick up not only from intestinal epithelium, transferrin can pick up iron from the liver cells, because that also storage point for iron. It's also there in the marrow, bone marrow. From there also iron can be picked up by transferrin. Transferrin can pick up from the spleen also, from the macrophages. All the time, the picking up of iron from all these sites is where of ferroportin channels. Now, these ferroportin channels is locked by whom? Hepcidin. Look how logical it is and how beautiful it is. Imagine if there is an infection that triggers certain cytokines. One of the classical cytokines that's a responder to inflammation and infection is interleukin 6. Now, interleukin 6 has got a direct impact. Imagine if the bacteria is there and it's multiplying. Now, you know bacteria, how fast the replication is. It's not like, they grow up to 30 years, then they find a mate, then they have kids. Okay, I'm talking about bacteria here. The replication time may be in few seconds to minutes. It's dividing very rapidly. Many of these dividing bacteria need iron as a very important cofactor. In their growth, in their replication, they need iron. And one of the defense the body does is, It produces interleukins like interleukin 6 that increases hepcidin. Hepcidin locks off the stores and holds the stores like Godon may. Ferritin is like Godon, store. It's storing the iron but not allowing release of free iron. So it closes the ferroportin channels here, it closes the ferroportin channels in the intestine, it closes the ferroportin channels in the liver, and it's not allowing the release of iron. Means all the iron is in the storage, and storage iron slightly leaks out in the blood, which we estimate as ferritin. So iron is there, but what starts decreasing? I mean, stored iron is there, which is ferritin, but what starts decreasing is serum iron. And without serum iron, the bacteria cannot utilize it for their replication. So beautiful defense by the body. It's trying to prevent the replication of many of these infections that might need iron as a very important factor. So it's a defense. You'll also see inflammatory conditions that hepcidin will increase. In all these conditions, inflammations, infections, you will see increasing in hepcidin will cause serum iron to drop, but the ferritin is still there. The opposite happens in an iron deficiency state. In an iron deficiency state, the first to decrease is ferritin because the stores will get depleted. A constant supply of iron in the serum is maintained because serum iron is required everywhere in the bodies, in the tissues, in the RBCs. Serum iron will be maintained until last. What starts decreasing first is ferritin. Opposite happens in patient anemia of chronic disease. Serum iron decreases even though ferritin is there. That's the important comparison you should know between the two, between iron deficiency and anemia of chronic disease. So we've discussed these things at length, and the logic behind many of these things is mind-blowing in the sense it's so beautiful, the human body, and the way it works, the way the defenses are. I think it's really remarkable. Anyway, this for my notes again. Master regulator of iron is hepcidin. Hepcidin release is inhibited when the RBC is replicating in the marrow. It needs iron. So one of the things, it will stop the hepcidin, allow more iron to come from the intestine, allow more iron to be released from the liver, marrow, spleen, everywhere you want iron to be released so that it's transported to the area. And when erythrocytes are replicating, erythroblasts are there, they produce something called erythroferrone. Okay, whenever you have developing RBCs, they produce erythroferrone. What does erythroferrone do? It suppresses hepcidin, allowing iron, because hepcidin locks the storage. It opens up the store so that iron is utilized. That's how the iron is released, and that's how RBCs can utilize it. But if the patient has got too much hepcidin, now how too much hepcidin can occur? Too much hepcidin can occur if there are interleukin 6 is increased, the patient has any kind of infection, patient has got any inflammation. If the transferrin is too much saturated, imagine if iron keeps coming, then one of the things is we don't want too much iron. Don't forget, ferrous is free radical, it's dangerous. So what the body does, it is going to whenever transferrin saturation is high, that means too much iron came, it will protect itself by producing hepcidin, and hepcidin will close the door and stop. Don't forget intestinal epithelium, whatever iron is building up inside the intestinal epithelium, the intestinal epithelium tissue will slough off, so extra iron will go off in the stools. So that's how it's protecting. Too much iron should not come, and this defense is broken in patients who have got hemochromatosis. In hereditary hemochromatosis, the HFE genes to some extent indirectly code for hepcidin. In hereditary hemochromatosis, no HFE gene, no hepcidin. Without hepcidin, the door is wide open. Iron keeps coming, even though transferrin saturation is high. There is no suppression on hepcidin. I mean, the iron keeps on coming, and because hepcidin is not there, okay, in hemochromatosis, no hepcidin. If there is no hepcidin, hemochromatosis, excess iron gets absorbed. What happens to transferrin saturation in hemochromatosis? It starts going above 50%. Okay, in first question, Sakshi is asking how much adenosine should we give? We start with 6 milligrams IV, and don't forget, if you have a central line, 6 milligram generally works. If you have peripheral line, adenosine half-life is so short that generally we keep a 10 ml syringe loaded with saline. We push the adenosine and immediately push the saline, allowing faster movement of the adenosine towards the heart. And you will notice as soon as you give the adenosine, within seconds, as you're observing, you will notice the rhythm converting to normal. So that's how fast adenosine works. Okay, so that's Sakshi's question. That's why I went to adenosine. Coming back about hepcidin, two important diseases we saw. Anemia of chronic disease, hepcidin is increased. Hereditary hemochromatosis, hepcidin is absent. These are differences that are there between iron deficiency and anemia of chronic disease. In both, serum iron will decrease eventually. Okay, what starts first of all? In iron deficiency, ferritin decreases first. What decreases first in anemia of chronic disease? Serum iron decreases first. Even though storage is there, serum iron decreases first. Okay, that's the difference I was trying to tell you. But eventually you'll see in both serum iron will decrease. But the big difference is here the stores get depleted, but here the stores are there. Stores are there, but the body can't utilize because ferroportin channel is locked because of hepcidin. As you know, ferritin and TIBC go opposite direction. They are inversely related. Okay, if there's more store, the liver produces less transferrin and there will be less total iron binding capacity. So here ferritin is low, so liver produces more transferrin, more availability, more sites available for binding iron. So total iron binding capacity is increased. So a simple idea is keep ferritin and TIBC in opposite direction. If ferritin is low, TIBC is high. If ferritin is high, TIBC is low. That's what you see here. Ferritin is high in anemia of chronic disease. Because of that, total iron binding capacity will be decreased. One of the major differentiators is the transferrin ferritin index. Okay, this transferrin ferritin index is basically a ratio of serum transferrin receptor. It's not transferrin receptor divided by log ferritin. If the ratio is more than 2 or less than 1, they're supposed to have very good sensitivity in differentiating iron deficiency anemia from anemia of chronic disease. Okay, more than 2 and less than 1. 1 to 2 is supposed to be normal. So more than 2 and less than 1 helps us in differentiating between these two conditions. So all these are very important ways how we differentiate between iron deficiency and anemia of chronic disease. Okay, so I think this is pretty easy stuff. I don't want to go too much into detail. We've covered all this in our lectures at length. Moving to the next one, which is not useful in the management, which is not useful in the management of sickle cell anemia, and the answer is, you know that sickle cell anemia, the whole problem is in hemoglobin S that is there, hemoglobin S in deoxy state. Okay, hemoglobin S in deoxy state is the one that starts sickling, and it makes the cell rigid. That does not allow flexibility of the RBC, and also hemoglobin S increases stickiness, allowing more RBCs to bind to each other, and it dehydrates the cells, and that's how sickling will occur. And sickling means it causes vaso-occlusion. It blocks off small vessels in the blood. Every inch of the human body, as you know, requires oxygen. So if blood vessels get blocked, that area will infarct. So infarcts can occur anywhere. That's the core problem of hemoglobin S that causes sickling. But as I told you, sickling occurs in deoxy state. So what we are trying to do is we're not allowing deoxy state to occur. In the process of not allowing deoxy state, we're using these two drugs. Glutamine we've covered in our classes. Glutamine is an antioxidant. It's a free radical, it makes sure that the free radical scavengers are maintained. The glutathione stores are maintained. So glutamine helps us in preventing the deoxy state to occur. It is going to keep the, oxidative state. Vexillitor is also another thing that increases oxygen affinity, and if increases oxygen affinity, then because of oxygen being present, it will not allow the the stickiness or the deformity to occur in hemoglobin S. So basically, both these drugs that are there, glutamine and voxelotor, both of them are going to prevent sickling. The mechanism of action of hydroxyurea is different. Hydroxyurea works by increasing hemoglobin F. Again, as you know, hemoglobin F also has got higher oxygen affinity. Not only that, hemoglobin F does not have stickiness around it, so it will not allow sickling to occur. That polymer that will form, that if hemoglobin S is there, one hemoglobin F in between, if one hemoglobin F, let's say this hemoglobin F, it will block it and it will stop the polymer from extending. So it doesn't have the stickiness, so it will not allow further expansion of the polymer. So that's the benefit of hemoglobin F. So we increase hemoglobin F colony forming units by hydroxyurea. We decrease the free radicals by using glutamine. We use a drug that increases affinity of oxygen and decreases sickling. This drug is voxelotor. All these are used, but the drug that is there, bebtelovimab, is so difficult even to pronounce this drug. But this is a monoclonal antibody approved in the treatment for COVID. So COVID-19, some of the new drugs that are there, I'll just show you the things. And Harrison, what is saying in the new 21st edition, I'll just show you some of those things. Anyway, before we go ahead, this is the treatment that I've shown in my notes in sickle cell. One of the major areas for MCQ is exchange transfusion. They do ask indications for exchange transfusion. You should be aware of it. So stroke, acute chest syndrome, splenic sequestration surgery, acute hepatic injury, and symptomatic anemia. These are the places where exchange transfusion has a role. Do not use transfusion if MCQ is only talking about pain or the patient has anemia, the hemoglobin is more than 7. Or the patient has got asymptomatic anemia, don't answer transfusion. Okay, those are conditions where transfusion not used, exchange transfusion not used. Why are we giving exchange transfusion? We're giving hemoglobin A, removing hemoglobin S. Hemoglobin A also, just like hemoglobin F, will not allow expansion of the sickling unit. That's the benefit of using hemoglobin A. Okay, hemoglobin A blocks the further expansion of the polymer. So that's why we use exchange transfusion. Hydroxyurea, I told you already, it increases hemoglobin F because it stimulates the hemoglobin F, the gamma colony forming units. L-glutamine I mentioned in my notes, it decreases oxidative stress, it keeps the glutathione in a reduced state, and that's how it does not allow the formation of polymerization of hemoglobin S. All the problems are deoxyhemoglobin S. We don't want deoxyhemoglobin S. That's the way how we preventing sickling from occurring. Now, obviously, the curative treatment is bone marrow transplant. I also discussed in my class about a concept of gamma beta switch on which active research is going on, but further thing in this is yet to come. Anyway, this is CMD 2022. CMD 2022 does talk about hydroxyurea. It does talk about L-glutamine. There's one more drug it talks about. It's a monoclonal antibody. This has not been asked in this question, but it might be asked, and this is crizanlizumab. And this monoclonal antibody also reduces vaso-occlusive episodes almost by 50%. Okay, it blocks the P-selectin. By blocking P-selectin, which is there on endothelium, it does not allow the stickiness of this plug, and blockage of the vessel will not occur. Okay, this is crizanlizumab. How does it work? It's a P-selectin blocker. It's a monoclonal antibody. And finally, this is the drug, this voxelotor. How does it work? It inhibits polymerization of deoxy sickle red cells. Basically, as I told you, the idea is if you don't have deoxyhemoglobinase, if you have oxyhemoglobinase, no problem. The deoxyhemoglobinase is an issue for us. So this is going to increase affinity and keeps the oxygen, does not allow oxygen loss, so that deoxy state does not occur. That's the benefit of using voxelotor. So again, hydroxyurea, L-glutamine, crizanlizumab, not been asked in this question, but it's a P-selectin blocker on the endothelium and also decreases vaso-occlusive episodes. Finally, voxelotor. All these are the drugs that have been approved in the treatment for sickle cell. Now, I did mention in detail about this in my notes about exchange transfusion. So exchange transfusion, you should know the indications because they have asked in the exam before. So vaso-occlusive crisis, acute chest syndrome, priapism, stroke. The usual answer is pain. Severe pains can occur in sickle cell anemia because of vessel blockage, as you know, but that is not an indication for exchange transfusion. Okay, that is generally opioids. Okay, a few points about COVID-19. I was just very interested in seeing what 21st edition Harrison is doing about COVID-19. And unfortunately, as I told you at the start, we expected a lot to be there in COVID-19 Harrison 21st. It's not the case. They have just given few pages. And in that few pages, if you look at the treatment, it is talking about the general principle, which you all know, that the initial phase of COVID is going to be where viral replication is occurring and antiviral treatment dominates. Later part, when the immune system is reacting and causing the damage, the anti-inflammatory medications and immune suppressive treatment become the main treatment. So there are two phases of COVID management, the initial phase and the later phase where the inflammation is there. And the two treatments, initial antiviral treatment is, all the antiviral treatment is in the initial phase, the monoclonal antibodies, the remdesivir, all that is the initial phase. The later phase, when inflammation becomes the problem, the cytokine storm that is occurring, to control that, anti-inflammatory, anti-immune system treatment become more important in the later phase. So that's a broad principle even Harrison is talking about. Now, what are the things, this page number also is there in 21st edition, you can see. This is all the drugs Harrison is mentioning. It is talking about baricitinib in combination with remdesivir. Dexamethasone, obviously, as you all know, is the main treatment. Then tocilizumab, which is interleukin 6 receptor blocker. Then you have the other monoclonal antibodies. And among the monoclonal antibodies, see, he's saying finally, as for May 2021, these are all the drugs approved in the treatment. One is remdesivir. Then you have baricitinib and remdesivir combination. Then you have the SARS-CoV-2 spike protein. Against the SARS-CoV-2 spike protein, we have bamlanivimab. Then you have combination of carcimimab, imdevimab. So all these drugs are there, fine. But Harrison, I think, is still a little lagging behind because even though this 21st edition Harrison, it is talking about May 2021. Now, after that, more guidelines have come. One of them is the NIH guidelines, and then they have there are other drugs that are there now. I think the interesting drugs that are there might be asked in NEET, so you might have some idea about it. We all know about Paxlovid, which is the hot drug now. Chances are pretty good that it might come in one of the exams in the future. What is this Paxlovid? This trade name, obviously, this nirmatrelvir. Ultimately, you know, I've seen students remember only this word, nirma. If you see this word nirmatrelvir and ritonavir combination, this is a protease inhibitor. This is one of the drugs that prevents replication of the virus. Okay, so nirma, don't forget the word nirma here, right? Nirmatrelvir and ritonavir. So this is the combination. This is called Paxlovid, hot drug. We are expecting, a lot of randomized control trials showing benefit. So it is good. We all know about remdesivir. Does not have mortality benefit, remdesivir, but definitely decreases hospitalization. The other drugs that are there, the other drugs that are there are the bebtelovimab that is mentioned in this question and molnupiravir. Now, molnupiravir actually induces mutations in the replication of the virus. The worry that is there is, what if our normal cells that are replicating, in that if there is mutation induced in the replicating thing, then will it not create a future risk of malignancy or other potential problems? That is yet to be ascertained. That's why people are not very confident of prescribing it. But this is one drug, bebtelovimab. I'll just show you again. Then you have the steroids, dexamethasone are always there. And all this, NIH is talking about mild disease, which are non-hospitalized patients. That means the initial phase antiviral drugs that I'm talking about, where the patient is not got severe enough to have desaturation and enter the hospital. So all these are the initial treatments. Now, hospitalized patients, for hospitalized patients, they're still talking about the same thing. It is steroids, it is oxygen, it is remdesivir. Then we have the interleukin 6, that is tocilizumab, sarilumab. All these drugs are there. Baricitinib is there. So all these are drugs that they're talking about in hospitalization. You don't have to go into too much detail. Just remember the names of the drugs at least, because they might ask in the exam. Now, of all these, as I think, sorry, what might be asked are the new ones, and in that, this monoclonal antibody, tixagevimab and silgevimab, has been recently approved. What it is showing is it's a monoclonal antibody that covers up the spike protein and blocks the viral entry. This is pre-exposure prophylaxis. So people who are working in high chance of getting COVID, pre-exposure prophylaxis, this has been studied and it is showing benefit. The studies are showing 77% reduction in chance of developing symptomatic COVID in the future. Now, this is pre-exposure. Now, once a patient has developed the COVID, initial antiviral phase, we have a monoclonal antibody, which was asked in this choice, as you can see. This is the bebtelovimab. It's a monoclonal antibody against spike protein. It blocks viral attachment to host cell. Obviously, as you know, the entry point where spike protein is the main anchor, it attaches to the ACE2 inhibitor and enters inside. So the benefit, the studies are showing symptomatic improvement, and by day 5, significant reduction in viral load. That's what the study showed. But it is approved for mild to moderate COVID-19. Okay, this is the choice you saw in the exam this time. Okay, bebtelovimab. I already mentioned to you about remdesivir, you all know, but Paxlovid is what I am expecting a question on, because that's a hot drug. This is an oral drug. That's why also is another very important drug. Molnupiravir is there, but then I somehow don't think they'll ask much about it. Anyway, Paxlovid is Nirma. So Nirma Chelvar Ritonavir combination. It's a protease inhibitor that halts viral replication. 88% reduction in hospitalization and death. So that's pretty good, and that is RCTs that are showing it. Finally, you have Molnupiravir. I told you it causes nucleoside lock that inhibits viral replication by viral mutagenesis. So the cytosine, thymine, those nucleotides that are there, in that it creates mutation, and by doing that, it does not allow the normal sequence to occur for viral replication. Right, 30% reduction in hospitalization by molnupiravir. So molnupiravir, I think, is already available in India, but it's not there in the AIMS guidelines also. So I don't see how they can ask much questions on this, because we're still worried about potential mutations that can be induced in the normal cells in the body. But Paxlovid is, I think, hot drug, and we are already anticipating this going to be potential question in the coming exams. Okay, and if you forget everything, just remember the word Derma, and that's a hot drug. It's a protease inhibitor. So this is all the stuff that you should know as far as the COVID-19 is concerned. Now, which of the following is X-linked dominant? I think the answer is pretty obvious. You all know about X-linked dominant, that male-to-male transfer should not occur. Whenever female has got the disease, then the disease is going to go both to males and females. And there are some wrong things of some students I have seen understand. One is they feel that in the pedigree chart, they count the number of children, and they believe that X-linked dominant, 50% of the children should be affected. Okay, 50% males, 50% females should be affected. And they count the pedigree chart. And imagine if there are 5 kids, then they go into a toss of understanding what's happening over here. So that 50% that we learn about, be careful. Each child has got a 50% probability of getting the disease. Not that, the 50% of children. So if there are 5 children, how do you get 50% of that? So that's really funny. So the point is that 50% chance that of males getting the disease, 50% chance that the female might get the disease, not that 50% of children will have the disease. That's not the way. Whenever you have to have a male who's got the disease, 100% all children should have the disease. Okay, this is X-linked dominant, because male has got one X chromosome. When it goes to the daughters, every daughter over here will have the disease. So 100% daughters should be involved when a male has got the disease. Male to male transfer will never occur. Male to male transfer will never occur. So the pedigree chart is very easy to read. Every generation should be involved. That means it is dominant. Skipping is there, that's recessive. Here, every generation is involved, that is dominant. Once you have dominant, male to male transfer is not there. From female, it is going to both males and females. That picture is there, that's nothing but X-linked dominant. Once you decided X-linked dominant, should know some of the important causes. You all know the mnemonics, so many mnemonics are there. The most important is vitamin D resistant rickets. This vitamin D resistant rickets, also called as hypophosphatemic rickets. Okay, and this hypophosphatemic rickets is something called FGF23. The concept behind it is very interesting. There's something called FEX gene that is there in X chromosome that regulates the metabolism of FGF23. So there's a mutation there in the X chromosome, does not allow FGF23 to be metabolized. High FGF23 creates all the problem. So it's high FGF23 that is creating this hypophosphatemia. Anyway, that's a totally different vitamin D topic. Rett syndrome, Fragile X, Alport's, Charcot-Marie-Tooth disease, as you know, autosomal dominant also is there, even Alport for that matter. They can come with all kinds of inheritance pattern, but they do come with X-linked dominant also. So these are the important ones you should remember. Vitamin D deficient resistant rickets, that is hypophosphatemic rickets, Rett syndrome, Fragile X, Alport's, and Charcot-Marie-Tooth disease. Now, for quite some time, I have not been teaching psychiatry. I found this in one of my old lectures. I mean, I used to take psychiatry classes. Like I used to love teaching psychiatry. But this is from my old video. I mean, this is Asperger's, Rett's, childhood disintegrated disorder, autism. I used to compare because these diseases used to be given together in the exam. I mean, you should know how to differentiate. If you get a normal language with a person who is got problems in communication, even though language is normal, but they're not able to communicate properly, that's Asperger. Rett is what we're talking about. It's an MECP2 gene that is present on the X chromosome. So significantly, it's female disease. There are some rare reports of male disease, but mainly Rett's is a female disease. And both Rett's and childhood disintegrated disorder, which is known as Heller syndrome, have got two important findings. I mean, common finding. One is both these conditions, initial phase of growth is totally normal. In Rett's, up to 6 months, the baby is totally normal. From 6 months to 2 years, there is delay in the milestones and there is also regression. Okay, learned milestones are lost. Whatever learned milestones achieved by the child, that is also lost. Regression, hallmark finding of Rett's. In childhood disintegrated disorder, which is known as Heller syndrome, up to 2 years, second birthday, the child is totally normal, all milestones normal, physical appearance totally normal. That's Heller syndrome, right? Childhood disintegrated disorder. Up to 2 years, totally normal. After 2 years, from 2 to 10 years, the parents notice problems in a child and the milestones are significantly delayed. So much regression doesn't happen over here, but there is a slowing of milestones. The big difference between Rett's and childhood disintegrated disorder, physically there's a defect. You will see microcephaly. You will see the head is small. Okay, the head is small and the trunk is large. Okay, trunk might be normal, creating a physical defect that is visibly you can make out, but that doesn't occur in Heller syndrome. Heller's, the appearance is totally normal, and both of these conditions, however, they do come with anxiety problems in the children, which they try to prevent by doing something called repetitive movement. It's known as stereotypic movements. Imagine the child, any new position, any new environment he goes to gets anxious. How does it reduce the anxiety? Because these children have got something called ritualistic pattern. They have to have same thing every day. They have to same food. They like the same clothes. They don't want any change in the environment. Any change in the environment scares them, creates anxiety. So they create movements. And imagine viewing from the eye of the child. The child is seeing from his viewpoint. What he's doing is he constantly creates a movement. He might be banging on the floor. He might be banging on the head. Anything else in the environment may change, but what is constant in his viewpoint is that movement. He keeps doing that movement, these stereotypic movements that calms him down, and that's why these children have these kind of stereotypic repetitive movements. Autism, biggest thing is does not have the initial phase, normal phase at all. Like Rett's has got a normal initial 6 months phase. Heller syndrome got a normal 2-year phase. Autism, right from the start, something abnormal, the social smile, the attachment to the mother, everything is affected in autism. That's the way how we differentiate. Now, I don't want to go into more detail on psychiatry stuff, but I think 9 o'clock we had another teacher's lecture. If that teacher is watching, I apologize. I overstepped my time. I'm going to wind up pretty soon now. But I just want to tell you again, this is pretty interesting. I mean, psychiatry always been amazing. I think Dr. Ankur is teaching psychiatry in a brilliant way, and huge fans of Dr. Ankur. And I'm sure all of you must be benefiting. Anyway, this is about Asperger's. You have difficulty in communication. These people are sometimes gifted. They are experts in something which weird to everybody else. Like these people might know everything about motherboards or everything about RAM or everything about cameras, or they are experts in it. That's weird, fixation they have towards some specific interest they might have, but they have communication problems, social interaction problems. That's what Asperger is. So these are the diseases. They give it in a question. As you all know, the technique of preparing for entrance is the four choices that come. You should know how to differentiate. If your differentiating capability is good, then you can handle this question very easily. So there is, I think, an image that they had given about Gottron's papules. I'm sure you must have all got it right. This is nothing but dermatomyositis. Now, Gottron's has got papules on the knuckles. Imagine if you don't have the papules on the knuckles, but in between the knuckles, if you have the rash, it's on the knuckles rash, Gottron. In between the knuckles, if you have rash, that's one of the ways how SLE can present. There are other, diseases that can present with the rash that is there in between the knuckles, but on the knuckles, if you're seeing the rash, that's very classical. That is known as Gottron's papules. Gottron's, in my notes, we've covered how to differentiate polymyositis, dermatomyositis, and inclusion body myositis. And particularly dermatomyositis, I described about heliotrope rash around the eye. Is heliotrope rash. Gottron's papules, which is rash on the knuckles. Then the trunk rashes, if it's there in the front like a V sign, or sometimes on the back, it looks like as if a person is putting a shawl on their shoulder. This is known as shawl sign. Okay, so on the back you'll see the rash. This is known as shawl signs. In the front, if it's there, it's known as a V sign. Apart from this, these patients will have mechanics hands that look like mechanics. This is known as mechanics hands. A lot of creases and pigmentation in the hands. And just below the nail bed, you will see telangiectasias. This kind of telangiectasia just below nail bed, two places you'll talk about it. One is dermatomyositis. The other place you can see it is in scleroderma. Okay, so these two places you'll see something called periangual telangiectasia. This periangual telangiectasia. So you can get skin lesions without muscle, without myopathy. That's called dermatomyositis, sign myositis. So these are some of the points I mentioned in my classes about dermatomyositis. Ratio of T and B lymphocytes. The problem is the Robbins ratio, the way it is giving percentage, the way 21st edition Harrison is giving is different. I follow Harrison. So what Harrison is giving, this from 21st edition Harrison, mature T lymphocytes in the peripheral blood are 70 to 80%. And mature B cells in the peripheral blood are 5 to 10%. So if you take this ratio, then this is 70 to 80%. T cells are 70 to 80%. And B cells are 5 to 10%, sorry. Okay, 5 to you can see 5 to 10% are the B cells in the blood. So if you take this kind of a thing, then the ratio is going to be pretty high, isn't it? Even if you take it can be 8:1 sometimes, or 7:1. Whatever the highest I could get in this choice is 3:1. Now you might have got 4:1. That also is okay. You can answer 4:1 if it's there in the choice. But I think all the other choices were trying to show 1:1. They were trying to show more B cells. Some students marked that that's wrong. Definitely the ratio is either 3:1 or more than that. If you can get more than it also, that's fine, based on the way percentages Harrison is giving. So this is about the peripheral blood. Okay, don't confuse. This is different from lymph node and different from peripheral blood. Peripheral blood T cells are more compared to B cells. And the ratio is almost 4:1. MHC class 1, you all know this binds to cytotoxic T cells. MHC class 1 is inside the endoplasmic reticulum. Intracellular defense is controlled to some extent by MHC class 1. So any intracellular pathogen multiplies, the proteasome breaks it, presents as a trap transporter. It goes through the trap transporter and MHC class 1 picks it up. MHC class 1 attaches to the antigen and presents it to cytotoxic T cells. Okay, so you know the rule of 8. CD8 cells are connected with MHC class 1, whereas the helper T cells are connected with MHC class 2. Okay, MHC class 2 is extracellular pathogen generally. Intracellular defense is controlled by MHC class 1. So I think these are some of the easy ones. I think I'll stop now. I think another faculty is waiting to start his presentation. I thank you all for listening to my class. Sir is having laryngopharyngeal reflux. I think you're right. I am having a reflux problem from quite some years. Not only that, I think I've got COVID, and this is the third time I think I've got COVID. So I'm just recovering from that still. McCune-Albright syndrome. Is there a question on that? Okay, if you're asking about what is McCune-Albright syndrome, then the answer for McCune-Albright syndrome is it's a condition where Albright was working on. It's a gain of function mutation of GS alpha receptor. Okay, this GS alpha receptor that is there, it hyperfunctions. If it hyperfunctions, many hormones that act through GS alpha, they look like as if they are increased. Although the hormones are not increased, but the receptor is hyperfiring as if the hormones are increased. So in that process, you will see these patients have got three major features. They'll have cafe au lait macules. They'll have something called polyostotic fibrous dysplasia. And they have precocious puberty. These are three main features you will see in McCune-Albright syndrome. Albright was working on GS alpha receptor. As you know, loss of function of GS alpha is pseudo hypoparathyroid. Gain of function of pseudo GS alpha is McCune-Albright. So both were work done by Albright. One GS alpha not working, pseudo hypoparathyroid. That's called Albright hereditary osteodystrophy. Here, GS alpha is hyperfunctioning, and this is called McCune-Albright syndrome. So, McCune-Albright syndrome, classically, you will see cafe au lait macules, which have got wavy margins, not smooth margins. They have bony abnormalities. This looks because of parathormone is increased. Not parathormone increase, parathormone action is increased because receptor hyperfunctioning. And because gonadotropins work through GS alpha, patient will have precocious puberty. So, these three are the problems that happens in McCune-Albright syndrome. Where negative mark needed to get within 200. It totally is comparative. I mean, it depends on how the others have performed. I think this may not be a very high scoring paper. That's what I feel. What should be expected score to get a, see in all these years that I've noticed, anything above 65% is good. The percentages vary year to year between 65 to 75. That's a very big percent. Around 70 if you're getting, you're in the safe zone. That's what I think. In this paper, may not be very high scoring paper. So, I would say anything around 70% if you're getting, you should be feeling good. Below 68% may not be doing very well. Above 68, 70, between 60 to 74, around that is where I'm expecting most of the good ranks to be. So I think we've discussed at length the medicine questions, and I thank you all for being part of this. Anything about postponement? No, I don't think postpone will occur. I think it's better to start preparing for the exam, because the more you think about postponement, the more time waste you will do and less you will study. If it postpones, well and good, but if it does not, then this might affect your preparation significantly. All you need to do now in the last few days is don't waste time, in the sense, just think about the preparation around this time, because the heat is intense and people buckle down under the pressure. They kind of throw in the towel and give up. That's not what you should do. Because if you give a decent attempt, also last 10 days also make a big difference. As you know, in our kind of exams, last 10 days are very, very crucial. So don't worry about too much. I mean, don't think too much. The thing is, you feel like you'll do something great in the last 10 days. That is not possible. We are all human. If you do normal stuff also, that's great, I would say. At this, under pressure, this much also is too much. So all you need to do is get a target of around 10 to 16 hours. 10 hours is decent, 16 hours would be great, but 10 hours is generally what most of us can achieve under stress. When you're studying, don't think about what you will do if you get a great rank. Sometimes you study for 2 days properly, then you start feeling, if I study like this for 10 days, then I'll get a great rank. So stop dreaming about something that you're not even done still. And some people start regretting, I should have studied more, I didn't read that topic, I should have done this, I am not worthy, some nonsense you'll get. That is also wrong. Don't think about anything, just think about the next 1 hour. Keep it simple. Under stress, what works is small things. Next 1 hour, under 1 hour, that next 1 hour, how much portion of notes you are going to revise, focus on that and stick to that. Don't go into too much detail. Remember, in our system, it's just not possible to do everything. From most important to least important, just focus your attention down that road and don't go too much into detail, but just get a broad idea what is there in your notes and just scan through your notes. That's the whole picture. So just focus on the 1 hour by hour, inch by inch, little by little, small things. That's how you progress, and that's how you achieve great results. So just stick to that next 1 hour. That's all that you need to do. Don't think too much about what will happen once a rank comes, how bad you were in your UG days or something. I mean, don't allow any other thought. Just stick to the next 1 hour. In the next 1 hour, don't think about future, don't think about past, don't think about anything. Just stay in your present and focus on your notes. And that's all that you need to do. If you go through hour by hour, little by little, then you are going to be doing well at the end of the day. By the end of the day, you would have done reasonable amount of revision. So good revision with about 20-30% of your time utilizing for questions. That if you are able to do, I think you are doing well. And whatever we feel, ki last few days we'll do something great, generally may not happen. But be persistent, be focused. Don't allow any kind of thoughts of postpone or something. If it happens, well and good, it'll happen for everybody. But if it doesn't happen, you better be prepared for the exam. That's how you should prepare. So my best wishes to all of you, and thank you all for being part of this discussion. And good luck to all of you. I hope all of you do well in your coming exams. Thank you.